Satyabama Institute of Science and Technology, Chennai. Satyabama Institute of Science and Technology, Chennai. Technology, Chennai. Technology, Chennai. Technology, Chennai. Technology, Chennai. Technology, Chennai. Satyabama Institute of Science and Technology, Chennai. Satyabama Institute of Science and Technology, Chennai. Satyabhama Institute of Science and Technology, Chennai. Satyabhama Institute of Science and Technology, Chennai.
Good afternoon, ma'am. Can you hear me?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
Murugesan, sir,
Yes, ma'am.
reduce the volume so that Karthik sir can check up.
Okay, can I stop it, ma'am?
Yes, sir. Yes, sir.
Then only we can able to share the document. That's
Yes,
what.
yes,
Yes, sir.
yes, sir. Sir has joined, so we will get ready.
Okay. Now, sir can share the document.
So let me just share my screen.
Yes, sir. Yes, sir. Go ahead, sir.
So I hope you can see my screen.
Yes, sir.
Yes.
Go for a slideshow. Yes, we can have better visibility. Okay.
Yes. Murugesan, sir, will check the number of participants and wait for
Only
5
19.
minutes. Yeah.
Just 5 more minutes, ma'am.
Another 5 minutes they will join. Yes. Someone is asking for the link, Manjula ma'am.
Yes, ma'am. I'll share it.
Oh, Franklin ma'am is asking.
Shall I get started, ma'am?
Sir, 2 more minutes, sir.
Okay, sir. Okay, sure.
We are just waiting for more participants, sir.
Okay, ma'am. Sure.
Okay, 2:30 is the time, so they'll take just another 5 minutes.
Around 175 participants are registered, sir. That's why.
Okay, ma'am. Okay, ma'am.
So they'll all be benefited by your talk.
Okay. Okay, ma'am. Sure. Sure.
I think now they are they're joining, I think, right? 43 are there. Maybe another 2 minutes, we will start with the intro.
Sure, ma'am.
Yes.
It has become 2:30. You can start it now.
We'll start then, right?
Okay. Okay.
Okay.
Go.
Okay. Okay, thank you.
So, yes.
Good afternoon to one and all.
Sir, kindly, and we will give an introduction, sir. You
Okay,
can start.
sure, sure.
Yeah,
Sure.
kindly bear with us.
Sure, ma'am. Please.
So, good afternoon all. Good afternoon all. On behalf of the Department of Physics and our team headed by Dr. M. Manjula and Dr. S. Murugesan sir, I take a great pleasure to welcome the resource person for today, Dr. Karthik Chandrasekhar, and all the other participants to this FTP program. And we know that from the famous quote from Tirukural, கற்றதனால் ஆய பயனென்கொள் வாளறிவன் நற்றால் தொழார் எனின், which says that there is no benefit derived from learning if you don't worship the good feet of God, who is possessed of pure knowledge. So we have here Vasudhayan, who will sing the prayer song for us to begin the session. Vasudhayan, you're welcome to do the singing.
பாரத தாயை பணிந்து வணங்கும் வீரமைந்தர் நாம். பாரத தாயை பணிந்து வணங்கும் வீரமைந்தர் நாம். அர்ப்பணமாவோம் அவள் தாளினிலே தூய மலர்கள் நாம். பேசுகிறோம் நாம் பல மொழியானால் பேதம் இங்கில்லை. வங்கள மொழியும் இன்ப தமிழும் எங்களதென்றிடுவோம். வங்கள மொழியும் இன்ப தமிழும் எங்களதென்றிடுவோம். கவின் மலையாளம் கன்னடம் தெலுங்கு ஹிந்தியும் எங்களதே. கவின் மலையாளம் கன்னடம் தெலுங்கு ஹிந்தியும் எங்களதே. பாரத தாயை பணிந்து வணங்கும் வீரமைந்த நாம். அர்ப்பணமாவோம் அவள் தாளினிலே தூய மலர்கள் நாம். பேசுகிறோம் நாம் பல மொழியானால் வேதம் இங்கில்லை. ஆயிரம் ஜாதிகள் நம்மில் ஒன்று, ஆனால் நாம் ஒன்று. மாநில பலவாய் பிரிந்திருந்தாலும் மக்கள் நாம் ஒன்று. மாநில பலவாய் பாரத தாயை பணிந்து வணங்கும் வீரமைந்தர் நாம். அர்ப்பணமாவோம் அவள் தாளினிலே தூய மலர்கள் நாம். தொழில் செய்தாலும் கல்வி கற்றாலும் தேசத்தின் நன்மைக்கே. தொழில் செய்தாலும் கல்வி கற்றாலும் தேசத்தின் நன்மைக்கே. நாட்டின் உடைமையை நாமே அழித்தால் நஷ்டம் யாருக்கு? நாட்டின் உடைமையை நாமே அழித்தால் நஷ்டம் யாருக்கு? செய்தொழிலனிலே வேறுபட்டாலும் யாவும் அவள் தொழிலாள். செய்தொழிலனிலே வேறுபட்டாலும் யாவும் அவள் தொழிலாள். பாரத தாயை பணிந்து வணங்கும் வீரமைந்தர் நாம். அர்ப்பணமாவோம் அவள் தாளினிலே தூய மலர்கள் நாம். தூய மலர்கள் நாம்.
Yes, thank you, Master Vasudevan. So now I welcome officially all of the participants and the resource person for today to the 2 weeks FDP on pursuit of excellence in research and advanced technology. The objective of this FDP is to provide an interdisciplinary forum for scientists, engineers, technologists, industrialists engaged in the full spectrum of research and development, applications, and to discuss the current status and recent developments in science and technology. So this FDP is expected to be a common platform to present and discuss path-breaking research ideas and be an interface between academia and industry for societal needs. So in our yesterday session, our resource person, Dr. Farooq Balipnar, gave an insight on emerging thin film materials for solar cells. So today, let us focus on our next resource person, Dr. Karthik Chandrasekaran, and I invite Dr. M. Manjula ma'am to say a few words about sir. Thank you, ma'am.
Thank you, ma'am. Good afternoon to all the participants. I welcome you all for this session. And now we cordially will welcome our speaker, Dr. Karthik Chandrasekaran sir, for this session on robotic assisted surgery and future trends. Dr. Karthik Chandrasekaran sir, currently working as assistant professor in School of Interdisciplinary Design and Innovation, Indian Institute of Information Technology, Design and Manufacturing, Kanchipuram. He obtained his PhD and MS degrees in surgical robotics from IIT Madras in the year 2020. He received his Bachelor of Engineering degree in Mechanical Stream in the year 2008. He was a research engineer at ALGI Equipments Limited, Coimbatore from 2008 to 2011. He oversaw the development of a new rotary screw compressor unit. He was a research fellow in the Robotics Lab, Department of Engineering Design, IIT Madras from the year 2012 to 2015. He was acting as instrumental in the development of a teleoperated surgical robotic trainer as part of his PhD. He is adept at surgical robotics, product design, and the design of medical devices and manufacturing. His research interests include surgical robotics, compliant mechanism, soft robotics, and 3D printing. His invited talks include STTP on kinematic analysis and synthesis of robot mechanisms program at IIITTM Chennai, training program on robotics and automation IIT Madras, and Medical Expo 23rd edition Chennai Trade Center Chennai. And he has published a number of publications in various reputed journals with a high impact factor. So my hearty welcome for sir. So now I hand over the session to our speaker, sir.
Yes, ma'am. Thank you for your kind introduction.
Thank
Let
you,
me
sir.
thank Dr. Manjula, Department of Physics and team for the opportunity to present my work. So let us get started. So today's topic primarily will focus on, a little bit on the evolution of robotic surgery and a little bit on future trends. So it's actually a wide area. So let me just give an overall glimpse. I hope my audio is clear, ma'am.
Yes, sir.
Okay.
Clear, sir.
Okay. By the way, can
So
audience?
you would like to have your video? Your video.
1 minute. 1 minute.
Yeah, sure.
Let me just see. Yeah.
Thank you for
The
that.
camera is
Please.
unfortunately not at the optimal angle. I hope you
Oh,
can see
yeah.
it.
It's no problem, sir. Yeah, that much. Yes.
Yeah.
Thanks.
Yeah. So let us get started. By the way, can audience interact, ma'am? I thought this will be more of a. It will be more beneficial if it is an interactive session.
Yeah, sure,
If I can
sir.
directly. So,
Sure, sir.
are there any volunteers? Can you answer this question? Are all robots the same? Any volunteers, please? So, or let me pose the question in another manner. What comes to your mind when you think of the word robot? Any volunteers, please?
A machine.
Machine.
Sure.
Okay.
Sir, they cannot able to unmute themselves. Okay, it was locked actually.
Oh, fine,
Okay.
fine.
Because you can have disturbance in between, sometimes.
Okay, sir. Got it, sir. Okay. I thought generally.
If you want,
classes-
and I go for that provision. If you
Oh.
want, I go for it.
Yes, sir. Because generally, if it's an interactive sessions, classes.
Yes. Okay, sir. I'll go for it. No.
Because it is also we are doing it in an online format.
Yes.
I thought if the
Now they
audience
can-
participants. Yeah.
Now they can able to unmute themselves. No problem.
Yes. If we have any volunteers, what is the first thing that comes to your mind when you hear the word robot? Right? A mental image. You have a mental image, right? A construct in your head. Any volunteers, please?
From participants are asking some volunteers for.
Yeah. Any participant, you can just unmute yourself and then describe when you hear the word robot, what comes to your mind?
Now the option is given to unmute yourself. Okay, you can unmute yourself now.
And we have a number of young budding students.
Yes, please go ahead, please.
Anyone?
Okay. So generally, right, the common perception is when you hear the robot, it is a humanoid robot, something like Honda's Asimo, right? This is what comes to your mind. But robotics is something way beyond that. Actually, most of robotics, this only forms a small subset of the core field of robotics, right? The humanoid robotics. So, of course, Hollywood movies, recently our Indian, right? Movies like Indian have had a profound effect in the way we see the field of robotics, right? The way we approach robotics. But predominantly, the single core idea of robotics has been the humanoid robot, which is what you see here, right? But today's session, let me convince you that robotics is not only that, right? It's way beyond that. So to start the session, let me touch upon the remarkable prediction given by futurist and science fiction author Arthur C. Clarke. So in 1965, he writes, okay, he makes the following prediction. He says, it's possible that one day that some surgeon sitting in Edinburgh, which is in UK, right? This place is in UK, to be operating on a patient who is located in New Zealand, which is halfway across the world, right? So now please understand, this is a time when the core area of electronics was just evolving. Computers, you didn't have a personal computer to begin with. These hard disk storage, even to store a megabyte of memory, it will be the size of this room. So that was the state of development when Arthur C. Clarke makes this statement. But then the profound insight that he gave us actually came very true some 35 years later. I'll touch upon that in the upcoming slides. But what I want you to appreciate is the fact that somebody could actually very precisely foresee not only this, right, but then various aspects of it. So I would highly encourage the listeners today to please go ahead and then look at the famous book called The Space Odyssey 2000. There is also a movie based on that. If you're really into robotics, space exploration, that sort of a thing, the work by Arthur C. Clarke may be of interest to you, right? The reason why I'm beginning with this quote is he's making this even before the industrial robotics, the so-called what is called Puma 2000, which is a very famous robot. Even before this became the mainstream, he was able to make this prediction, right? So now let us look at a historical event. So NASA back in 1984, so they asked themselves the question, right? This was after the Apollo 11 mission, where NASA has sent men to the moon a couple of times. Now they ask themselves the question, in future missions, right? You're far away from home, you're sending a couple of humans in an enclosed capsule, they're traveling. What if any of them fall sick? What if there is a medical emergency? What if there is a medical trauma? If somebody is injured, they want to be operated. You cannot send a doctor, that's not possible. So what is the next best thing we can do, right? We can have what is called as an autonomous system that will operate on the patient, right? But even back then, the technology was so at its infancy, such a thing was not possible. Even today, it is not possible. I'll talk about what is called the levels of automation. What is called level 4 or level 5 automation. Only when you reach that state, you can have what is called as a purely autonomous system, right? Now today, most of the things that I'll speak about will be level 1 or level 2 autonomy, where it is supervised, where you have a human who is supervising the robot to operate on the patient. So NASA is, even today, it is even as recent as 2018, they've conducted what is called a teleoperation. So this basically means this idea comes from nuclear reactors. So nuclear reactor, basically you have to handle a highly radioactive material, which will emit a lot of radiation. So it is put behind lead wall. So I cannot directly reach out and then manipulate on the radioactive material. So we have what are called telemanipulators. These are mechanically connected devices using which you can interact with the radioactive material. Now, these were mechanically connected, right? Now, with any mechanically connected system, take for instance, today you have systems such as fly-by-wire. You have systems such as drive-by-wire. So the moment you connect an input with an output mechanically, that brings with it a certain level of challenges, right? A few of them are, since you are mechanically connected, the amount of force you have to apply has to come from the operator. Imagine you driving a car, you are holding the steering, and then when you want to make a turning maneuver, you have to turn it. Now, the amount of torque that is required without any force assist from the system, it is going to be quite high. The moment you have force assistance, or in other words, what we call power steering, you have either an electronic motor or a hydraulic system that is providing you with a force assist, right? Now, all you're doing is when you turn a steering, you are just giving in a control input. You're just telling the car, move to the left by so and so degree. That is all you're doing. So that system is also mechanically connected, but you get what is called as a force assist from the system. In the next evolution of such a system, what you can do is you can decouple the input, in this case, the steering, and the vehicle wheels. You can mechanically decouple them, not have them directly connected to each other, and then have them what is called electronically tether them. So think of a computer mouse, for instance. So when you do a scroll operation, what you're doing, basically you're turning a relative encoder. You're giving in a control input. You're asking the web page to move up. So in a sense, you're not physically connected to the web page per se. It is just an electronic signal that you're sending with the help of a mouse. And that is why you see the effect taking place through a software. So similarly, you have a system in certain cars. These are called drive-by-wire systems, where the steering wheel is not physically connected to the front wheels. Front wheels have a actuator, electric actuator, which moves the wheel based on the input command from the steering wheel. Now, the moment I mechanically decouple them, I can physically separate them, right? In other words, I need not even be sitting inside the car. I can sit outside the car because it is just a steering input. I can send them remotely, or I can have an autonomous algorithm that is driving the car, so on and so forth. So the key thing to understand is the moment we decouple a system mechanically, the input, the control input, and the actuator that is following the instructions, physical distance can be separated far away. So I'll talk about it in later part of the presentation. So the advantages of many. right? So NASA, when they asked this question, how can we address the problem of having a doctor in space? The idea is not to have a trained astronaut who knows everything about the human body. Rather, you put a system that will operate on the patient, which will have what are called the end effectors and other manipulable devices, right? And other necessary end effectors that will basically operate on the patient. The idea is you always have a trained doctor on Earth, right? He or she can be anywhere on Earth. So all you need is a reliable connection, a communication interface between the doctor who can be in any place in the Earth and the device, the slave device that is installed on the orbiting capsule. So now technically we refer to such a system as teleoperation. You're operating remotely, right? So these ideas are not new. They have been, as I said earlier, the ideas came from ideally from nuclear reactors. Now, back in 2008, the EU Commission, they commissioned a study on basically healthcare robotics. So the formal definition that they give for robotics for medicine and healthcare is as follows. So they say, based on their study, robotics for medicine and healthcare is considered the domain of systems able to perform coordinated mechatronic actions, right? What we call force or movement exertions on the basis of processing of information acquired through sensor technology with the aim to support the functioning of impaired individuals, medical interventions, care and rehabilitation of patients, and also to support individuals in prevention programs. Now, specifically, this talk, I will specifically only focus on medical interventions, specifically application of robotics to surgical intervention, what is called minimally invasive surgery, right? Now, the question we can ask ourselves is, why use a robot for surgery, right? Why use robotic assistance? So you have trained doctor who can take care of the patient, who can do a very good job. There are certain advantages in using robotic assistance for surgery. A robot is very precise and accurate. It is very repeatable, and you can have very high accuracy. And today, what is called partial autonomy, what is called level 2, or even some systems have what is called level 3 autonomy. Some level of independent decisions can be made by the robot, right? Without the assistance from the doctor. That is possible. The whole idea of bringing a robotic system is eventually we should be able to completely, replace a doctor, ideally. Because when you talk to any surgeon, they'll tell you, right? Something like, let's take an open heart surgery. It's extremely demanding on the doctor. Rather, what the doctor can be doing is perform more of a supervisory role to just ensure that the system is doing the job perfectly, rather than he or she actually working on the patient for 10, 12 hours at any given time, right? It would be better if they can just observe the system and look into the system to just ensure that the system does not does not misbehave, basically, right? So that is the level to which today the industry is moving. So that will happen maybe in another 20 to 30 years, we say, right? So nobody can say with absolute certainty, but that is the expectation. So at this instance, I would also like to point to the concept of what is called singularity, right? When we talk about AI, artificial intelligence in particular, we have this concept of singularity, where a computer algorithm, it is going to exceed the performance of an average human brain. Some scientists say it is expected to happen in as early as 2040. Some may push the number down to 2050, so on and so forth. So now, as far as robotic surgery is concerned, it is not only a question of having an autonomous system capable of decision making. So you should also worry about the physical system that can basically manipulate the tissue, right? I'll show you a couple of examples. Also, we saw the advantage of remotely operating a vehicle and how it will actually be physically away from each other, which means if you have a patient, right, let's say in a battlefield, or let's say on another planet, right, or in a very inhospitable, very inaccessible region, right, a soldier who is in a battlefield, the doctor need not physically go there. All you need is their expertise, right? They take hold of a couple of systems, the input devices, given the command. Okay, please understand, this is called our robotic assisted surgery. So a robot is only providing assistance, right? It is not fully autonomous. Please keep that in mind. And Robotic assistants can also provide what is called hand tremor compensation. What do I mean by this? So you just try holding a pen at your arm's length. Try holding it for 5 minutes. At the end of 5 minutes, you can see that your arm starts shaking, right? If I'm doing, let's say, if I'm doing an eye surgery, right, where the blood vessels are extremely small and very dense also. Even a small mistake there, you can harm the patient. So a doctor, they say, has to have the eye of an eagle, right? So he has to have a very clear vision, but has to also have a very steady hand. Unfortunately, as a doctor gets older, what happens is because of physiological changes, hand tremor tends to go up with older people. Now, especially for eye surgeons, that's quite a challenge. So robotic assistants can provide what is called hand tremor compensation. If my arms are shaking, right, if I'm holding a surgical tool, basically I can provide compensation. I can cancel out the vibration, the hand tremor in my hand. That is one of the key advantages of using robotic assistants specifically for something like neurosurgery and eye surgery, right? Also, operation in hazardous environments. Imagine a doctor keep placing a stent, right? They're doing an angioplasty. They want to clear out a block in a coronary artery. So, which means they have to be very precise in where they place the stent. So generally it is done through what is called continuous fluoroscopy. The doctor is continuously taking multiple x-rays. The problem is for the patient, it is a one-time job, right? The patient undergoes surgery, comes out. For the doctor who is operating, every day he or she is exposed to objectionable radiation. So if we can have a robotic system that can do that replaces the doctor, it is a welcome change. And we can do what is called motion scaling. What I mean by this is, some of you may be very familiar. You can set the mouse pointer speed on your PC. Some people would prefer a large motion of your mouse to move the mouse cursor by a small amount. So in this case, I'm scaling down the movement. When you scale down a movement, your motion becomes very accurate, but you have to move a lot of length. You can also scale up the motion the other way, right? I can map it in such a fashion that when I move my mouse by a small amount, the mouse pointer moves by a larger degree. Generally in robotic surgery, you scale down your movements by a factor of 2 or 3. So the reason why we do that is, if I have any tremor, right? Tremor is an inadvertent motion, right? It is it's an unintended motion. The doctor doesn't want that, but it is invariably, it is fed into the system. When you scale down the motion, the frequency component, right, of the amplitude of your tremor also goes down. So that is one key advantage of using robotic assistants for surgery. Now, I was talking about levels of autonomy. Now let's briefly look at the different levels and what do they mean. So this is actually taken from, actually these standards come from automotive standards, Society of Automotive Engineers, J3016, because automation primarily today you can see, right, the Teslas and other manufacturers following. So the standard is typically now set by the automotive industry, and typically for medical robotics also we adopt these standards. So level 0 is there is no autonomy, right? It's very clear. Level 1 is what I was talking about, telemanipulation. Robot cannot do anything on its own. I will talk about the Da Vinci robot. Robot is actually kind of dumb. The robot cannot do anything on its own, but it will do exactly as you say, right? Which means the doctor has full control. The doctor is using a system that is electronically tethered. So that is level 1 autonomy. Level 2 means partially automated work. What do I mean by this? One example is orientation of the camera vision to the tool. What I mean by this is, so in a surgical field, you put multiple instruments into the patient's body, and you also put a camera. Often you will see a doctor only has 2 hands, right, to work on the patient. Now, he needs what is called as an assistant nurse. There will be a nurse holding the camera, or there will be an additional setup that will be holding the camera. So if he wants to change the angle of view or the field of vision of the camera, he has to either instruct the nurse who is holding the camera, or he has to physically move it himself. We will look at some of the historical developments when I get to that slide. Level 3 is highly automated work. Now, this is quite famous because of spread of COVID. This is something we are familiar. transportation of, let's say, syringes, medicines around the hospital. This is something like your Amazon warehouse robot, right? Where from point A to point B, you have an autonomous system that carries whatever is the payload from one point to another. This is level 3 autonomy. Level 4 is fully automated work. For example, again, in a surgical setting, maybe after I explained the minimally invasive surgery, I understand some of you may not have the background in what is called MIS. So after I explain, I'll come to this point. And level 5, this is what we aspire to do someday, right? Full autonomy, right? Independent decision making. The system does not need a human supervision. It can completely function on its own, right? Such systems are still, relegated to fiction, but maybe in another 10 to 15 years, they are very likely. Now, I was talking a lot about surgery. So let me give you a brief overview of what do I mean by minimally invasive surgery, MIS, right? In minimally invasive surgery, typically what we do is this. So let us look at an open surgery before talking about MIS. So in an open surgery, what we do is, let's say you want to access, let's say we perform a simple procedure such as an appendectomy, right? I want to remove an infected appendicitis. I want to remove that, which means I have to make a very large incision. In case of an appendicitis, you make an incision here, somewhere here. The moment you do that, you have a huge hole, right? You cut open the skin. Now you have access to all the internal organs. My field of vision, I have a direct vision into the operating site. Now, what are the advantages of this system? I have a direct line of sight. I directly see the organ on which I'm manipulating, right? I can see the organ I'm manipulating. What is the second advantage? I can touch and feel the organ. I have direct contact with the organ. So it is very easy for the doctor to perform a surgery with an open surgery. But for the patient, since you have opened up, you have made a very large incision. Incision means a large opening. Since you made a very large opening, the healing time for the patient is very long, right? It's going to take a couple of weeks or even months if the incision is really long for the patient to heal back and get back on their feet. So from a patient standpoint, this is not preferred. Also from an infection standpoint, this is not preferred. The moment you cut open, you open up the internal organs, a sterile region to outside bacteria and viruses. So back in the 90s, they pioneered a method called, it is invasive. Invasive means I am going to get into the body using some modality, but instead of making a very large incision, now I'm going to make a multiple number of holes. These are called incisions, right? In this case, we have 4 holes to access, in this case, liver, right? This shows how do we access liver. Now, the advantages are, I'm not making one large hole, I'm making multiple small incisions. So these can heal faster. And it is sealed, which means the chances of infection is lower. Now the problem is reversed. For the patient, this is a very good thing because I'm making multiple incision. If I'm doing an appendectomy, right, on a patient, the patient can be discharged on the second day, right? They need to be hospitalized only maybe for a day or two, done. For the doctor, because I am not directly looking into the patient abdomen, I cannot see the organs directly. I need a camera. In this case, it is called as a laparoscope. I need a laparoscope through which, imagine you looking with a pipe into the human body, right? Now the field of vision is made very narrow. In this case, it's very narrow. I don't have a direct line of sight. And I have to keep moving the laparoscope back and forth, right? I have to pitch it, I have to roll it back and forth to see the entire area, the entire surgical site. Now this becomes very cumbersome. Vision is highly reduced. Also, we put in the surgical tools through what are called trokers. Trokers means you put in a couple of tubes through which you insert the tools and you manipulate the tissue. You operate on the patient. Now you have what is called these slender rods, just like the stylus that I'm holding. You put in through these trokers and then you have to operate on the patient. For the doctor, this is actually very cumbersome, right? So they need to be specifically trained. For a doctor who is used to open surgery, for them to switch over to laparoscopic surgery, it is going to take them several, at least the doctors I've interacted with, they tell me at least several thousand hours, right? It's not hundreds of hours. You need to practice for thousands of hours for very complicated procedures to be really adept at this minimally invasive surgery, right? Now that is where we bring in the assistance of a robot, right? This transition, if you really use a robotic way of approaching this procedure, it'll provide a lot of benefit. I'll show you why in the upcoming slides. Now let us spend a minute or two looking at the evolution of robotics, specifically in the context of surgery, right? Now this Puma 200, it is a very famous robot. It is an industrial robot specifically meant for what is called a pick and place operation. So I need to move one object in an assembly plant, right? In a manufacturing plant, there are a lot of assembling going on. Now let's say this has to pick a screw from one bin to another bin, or move it from a bin to a component. That is the actual intent of building this robot. So in 1985, a couple of doctors and scientists got together and said, okay, we have this industrial arm. Can we somehow use this for robotic assistance? So they said, okay, let us try doing what is called brain biopsy, which means I have to drill. Okay, you have to drill the patient's head, put a very small hole, very precisely put the tool, extract a sample tissue from the brain, come out. That is the procedure. Biopsy is typically you are retrieving a very small portion of the tissue, portion of the brain you have to take out for sampling. Okay, the patient may have tumor or some other ailment. Only if you take the tissue, you can test it and then really assess the condition of the tissue. Which means if I cannot make a very large incision on the brain, right, that will be bad. So, and I cannot do it manually also, because if you see brain, it's very, very sensitive. Brain doesn't have pain receptors, which means if I poke your brain, you will not feel the pain. Unlike your outer body, where if I poke anywhere on your body, it pains. Unfortunately, if I cut your brain in the wrong region, it will not pain, right? So the patient can even be paralyzed. So neurosurgery is extremely, you have to be very precise and you have to have very good guidance. So that is why people said, okay, let us take a couple of x-rays. Okay, if they suspect a tumor, I have to precisely only put the needle in that region where the tumor is, where you suspect a tumor, remove the tissue only from that region and recover, right? So they programmed a standard industrial arm for this procedure and they were quite successful. This was in 1985. Now the problem is, this system was not meant to be used in a medical setting, okay, which means they had multiple challenges. So we'll see the evolution as we move along. So the next evolution is the same Puma 200. At the end of the 1985, they did what is called as a resection. Okay, I will not go into the details of it for the lack of time. Now, in 1998, this is one of the very first dedicated robot. Okay, this robot, unlike the previous robot, Puma 200, which was repurposed, which was actually meant for something else, for an industrial operation. Now you're using it for a medical intervention. Now this robot was specifically built for prostate biopsy, right? Similarly, from prostate, when they have to take a sample, specifically they built the system to do this job. This was in 1988. Next comes what is called as Robotic. So many of you may be familiar with knee replacement, hip replacement, right? Joint replacement, basically, right? Some people, what happens is because of wear and tear, they'll have because of arthritis or osteoporosis, multiple reasons, right? Your joint may have been worn out so badly that the pain will be unbearable. People go for completely replacing it with an artificial joint. Now, the challenge in replacing the joint is, right, as how one of my teachers used to say, orthopedics is like carpentry, right? It is like, imagine you're building a table. All the edges have to be perfectly at the right angles, right? Even if one joint is not done properly, then your table is not going to look right. Now, this is the case of a table. Now, imagine you standing, and then I have replaced maybe your left hip or your left knee, and then it has become slightly shorter, right? Which means you cannot stand straight. So now when I talk about the biomechanics and all that, the alignment is very critical, right? It is not just cutting the bone and putting in a artificial replacement and hoping it will work. So you have to be very precise, and then you have to restore the exact same degrees of freedom with the exact same constraint as it were before. So people are doing guesswork, right? Before 1992, doctors, only a very highly trained doctor can carry out the procedure. And it is also not guaranteed that the surgical outcome will be good, right? The doctor can also mess up the procedure. It is likely, right? So people said, okay, let us look at robotic systems, see if we can precisely align the replacement knee to exactly where it should be, right? So that system came to being in 1992. Next system. Now, this is one of the very first telepresence system. Telepresence is different from teleoperation. Telepresence means now it is like some surgeons are doing a procedure, right? Remotely, not remotely, they are physically doing a procedure, and they need sort of a guidance, right? If I'm a young doctor, or if I'm a doctor, I may be an experienced doctor, but certain procedures might require advice from a colleague who is maybe from a different country, right? So in that case, I just like what we are doing now, I'll just call them up, maybe through a Zoom call or a Google video. They're going to be present there through, typically it is called a telepresence, right? They are not physically present there. Through using through the internet, they are also physically, they are observing the procedure. So that is called a telepresence. Next, we have what is called a Jet Propulsion Laboratory from NASA. Because NASA, as I said earlier, they're very interested in space healthcare, right? Let's say if an astronaut, you spend thousands of hours training an astronaut, right? Let's say maybe a couple of years, right? US is planning to send a human to the Mars. Let's say if they end up getting into an accident on Mars, right? They need medical care. What do? Right? You put such a system, and then remotely you try to teleoperate. So again, these are really far off, whatever I'm talking of. But then this is in the pipeline. A lot of people are working in this area, right? So in this case, you can see you have what is called as a master, which is what this person is holding. So they'll be holding, they'll be moving it. And then you have what is called as a slave, which will precisely follow all the instructions from the master. As I said earlier, these are not mechanically linked, these are electronically tethered, right? Next, we have what is called as ASOP. So this is a voice activated system. So earlier in the previous part of my lecture, I was talking about what is called as, you need an additional nurse to hold the camera, the laparoscope. So the problem is, if you go to any operation theater, you will see doctor will be doing the procedure. He'll say the nurse, okay, move to the right, move to the left, pull up the camera, push in the camera. These sort of instructions he'll be continuously giving. Sometimes if the nurse is, let's say you do this for 10 hours at a stretch, the nurse, they have to hold a camera which may weigh half a kg or 1 kg, right? It's pretty heavy. Or you may have a holder for the camera, they may have to just move it. But then, since I'm giving voice instructions, the nurse may not exactly follow what I intend, right? The doctor is interested in one particular area of the organ. The nurse may not exactly place the field of vision centered on what the doctor wants it to be, right? So this is always lead to a lot of exasperation for the doctors and for the patients working, right? This creates a lot of tension in the operation room, which we don't want. So a company called Computer Motion in 1994, they came up with this system. So what does the system do? All you do is you give the camera to this, you attach it to this system, and then you give voice activation, camera up, camera down. So I'm talking about voice recognition in 1994, way before any of your Android or iPhones, right? These systems were there close to 30 years back. Then we have by the same company, this company is no longer there. They built a system called Zeus, right, in 1998. Now this is